Top Med Talk.
Nick Majerison here. From October the 8th to the 12th, it's all about Dingle on Top Med Talk. Evidence-based perioperative medicine, EBPOM, is proud to present the 21st current controversies in anaesthesia and perioperative medicine and the SIAA Autumn Congress. Check out ebpom.org/meetings to find out more. Then, from October the 19th through to the 23rd, it's Anesthesiology 2019, the annual gathering of the American Society of Anesthesiologists in Orlando, Florida this year. Top Med Talk will be covering the conference from day one with live streaming of our conversations from the booth and unique content. Check out our website for more details, www.topmedtalk.com. That's www.topmedtalk.com.
And our next speaker is actually, it's a pleasure to introduce a colleague for the EBPOM International Visiting Lecturer. It's Dr. Evan Kharasch. Evan is a MD PhD who has joined as a professor at Duke. He is also Vice Chair for Innovation, a title I think is rare in our specialty among the departments, as well as the Director of Academic Entrepreneurship for Duke University School of Medicine. And additionally, you may know him as the editor-in-chief of the #1 journal in anesthesiology, which was just, we may hear some British journal, but which was just defined about a week ago. And on that note, he'll be speaking on opiates, and in particular on methadone, an overlooked opiate. Evan?
Thanks, Lee, very much. I'm very appreciative of the opportunity to speak here. This is the first time I've attended the meeting. While we're getting the slides up, I do want to thank Professors Maithan and Grokat for the opportunity to be here, to speak here, and also thank my colleague Tim Miller, who approached me and said, would you like to do this? And he knows me well enough to know that if anybody asks me to talk, I will always accept the invitation. So I wanted to talk about something which is a little bit different than the way many of us think and the way that many of us may practice medicine. I want to talk about methadone, and I was given the title of the overlooked opioid, which hopefully I will address that. But I also want you to start with and leave with a concept, and that is that methadone is a unique drug because it is what I like to refer to as an opioid-sparing opioid. And we talk a lot today about opioid sparing, and in many ways, methadone is an opioid which spares the use of subsequent opioids, and hopefully I'll convince you of that. I don't have relevant disclosures, but I do have a relevant bias. I've been giving anesthesia for 35 years. And there have been many trends in anesthesia. There are many trends in clinical medicine. Many years ago, I wrote an editorial about the concept of fashion, and hemlines go up and hemlines go down, and ties get wide and ties get narrow. And drugs and practices come in favor, and drugs and practices go out of favor. And in the past few years, we have seen a tremendous swing of a pendulum from the concept of balanced anesthesia to one of opioid sparing and in many quarters opioid free. And this has been exacerbated, certainly in the States, by some societal factors, to where I think that the pendulum in many ways has swung very far to one side. And the question is, are we really doing the right thing for the patients for whom we care? I opened up the New York Times a little more than a year ago and found a full-page ad. I have no idea what it costs to buy a full-page ad in the New York Times, particularly in multiple colors, but it can't be cheap. And this was the ad talking about the opioid crisis in America. It says, the president has declared a public health emergency, and now what? And the next line down said, hospital operating rooms across the country are functioning as unintended gateways to opioid addiction. And I won't show you the next line down because the print does start to get small, but essentially the theme was that patients were going to the operating room, anesthesiologists were intentionally addicting them to opioids, and patients were suffering. Now, the part that I won't show you is that this ad turned out to be sponsored by a pharmaceutical company that didn't make an opioid. But this is how some of the issues have been hijacked in many ways. Swinging the pendulum all the way over to the other side is that we have the movement for opioid-free anesthesia. And you know that something has really hit mainstream when there's a society for it. And there is a society for opioid-free anesthesia. It's the SOFA. And it says that you should ditch opioids and join the movement. And I, of course, was quite curious. And I like to poke around with my mouse while I'm eating lunch. And I thought, what's the movement? And so this was the movement. And the movement says, avoid all opioids during general anesthesia by relying on hypnotics to induce sleep and use drugs that block the autonomic nervous system response to pain stimulus, which is basically general anesthesia with propofol and esmolol. And I won't ask this audience, but I do often like to ask audiences of anesthesiologists how many, when they have their major surgery, want their anesthetic with propofol and esmolol. Nobody's ever raised their hand. And another aspect of this, we talk about patient-centeredness. So let's look at this issue. There was an interesting article in The Economist a couple of years ago talking about end-of-life issues. And if we look at Americans, particularly elderly Americans, an interesting statistic is that nearly a third of elderly Americans undergo surgery in their final year of life. Surgery is a pre-morbid event for a third of elderly Americans. And is this the population from whom we want to withhold adequate analgesia? I don't think so. We talk about surgery. There's mild surgery, moderate surgery, and major surgery. And surgery hurts. We sometimes forget that. We talk a lot about opioid sparing, and that's very relevant. It's even more relevant when we talk about sparing the side effects of opioids, not the analgesic effects of opioids. The question is the merits of opioid-free anesthesia, whether that's intraoperative or postoperative or even post-discharge. Because in many ways, if we don't give somebody opioids, the next person who takes care of a patient will. And if they don't, patients can have access to opioids when they leave the hospital. They self-medicate. We need to be aware of that. We sometimes forget about the very simple yet very relevant World Health Organization analgesic ladder. Non-opioid analgesics are very effective for mild pain. Moderate to severe pain is not adequately taken care of by non-steroidals and acetaminophen alone. And I think it's important to keep that in mind from a patient-centric perspective. So I had the opportunity a few years ago to write an editorial. Actually, it started as an editorial and it turned into a much longer commentary piece published in Anesthesiology. And I did it with one of my surgeons when I was at Washington University in St. Louis. Because he and I found that we thought very similarly about some of these issues. And we identified three major challenges that we saw in the perioperative period. The first was providing adequate analgesia to patients. The second was the problem of postoperative respiratory depression. And the third, which was imposed upon us in many ways, was the consequences of what has come to be called the opioid epidemic. And this is obviously country-centric in the United States, in many ways owns that opioid epidemic or opioid crisis. But we can't ignore it in the States because it influences so much of what we do and how we do it now. So the first challenge is analgesia. And there's some interesting information. Surveys of patients have disclosed or found that 80% of patients report that they had inadequate post-op pain relief. We like to think that we do a good job, but when we ask patients, they tell us otherwise. 80% say that they had inadequate post-op pain relief. And this is a survey which is done every 10 years, and the numbers haven't changed in the past 20 years of the survey. We know that chronic post-surgical pain affects 10 to 50% of patients. I like to ask my surgical colleagues when they pre-op their patients and get informed consent. I say, you tell them about the risk of infection? Yes. Do you tell them about the risk of bleeding? Yes. Do you tell them about the 10 to 50% risk of chronic post-surgical pain? And they look at me like I've grown another head. We also know that acute post-surgical pain is the single biggest risk factor for chronic post-surgical pain. And we also know that acute post-op pain causes complications over and above chronic post-surgical pain. The American Pain Society issued a set of guidelines on managing post-operative pain, and they too called out the issue of 80% of patients reporting inadequate pain relief. 3/4 of patients said that their pain was moderate, severe, or extreme. Half the patients said that their pain relief was inadequate. And that inadequate pain relief affects recovery, affects quality of life, it affects return to fitness, it affects the ability to care for oneself, one's children, one's loved ones, increases the risk of post-surgical pain. And I'll just share with you a data point, because we tend not to think about pain and post-surgical complications. But there was an article just published a couple of weeks ago which pointed this out. They looked at 1,000 patients, and they found that half of them had severe pain on post-op day 1, and that 1/3 of the patients had a significant surgical complication within the first 30 days. And they found significant associations between the incidence of post-op pain and those surgical complications. For example, when they looked at the relationship between post-op pain and complications, if you will, if the pain was unacceptable, there was a 2-fold increase in the risk of complications. They looked at the association with infections, specifically surgical site infections and urinary tract infections, and they found that if there was severe pain, there was a 2.5-fold increase in the incidence of post-operative infections from acute, inadequately treated post-surgical pain. So post-op pain is associated with complications, surgical complications. The second challenge we face is respiratory depression from opioids, specifically. They're common after surgery. Depends what metric you use to quantify respiratory depression, whether it's a pulse oximeter, the administration of naloxone, desaturation. The numbers vary, but opioid-induced respiratory depression does occur. There was just a study published that looked at this very quantitatively and found that the overall opioid overdose rate in hospitals was 83 per 100,000 cases. Nearly 2% of those were fatal, and that translated to 1.4 deaths per 100,000 cases. I often will visit busy hospitals that have 50 to 75 to 100,000 surgical procedures a year, and I like to ask, how many untoward post-operative deaths did you have last year? And the first thing that happens is everybody looks at their shoes. And then somebody will look up and give me the number. And it's usually 1 to 2. And that fits exactly with these data. We also know that the most serious post-operative respiratory depression occurs in the first post-op day, the window of vulnerability, if you will. The Anesthesia Patient Safety Foundation has said that no patient should be harmed by opioid respiratory depression, and I don't think anybody will argue with that. But I don't think we've achieved that goal. Certainly not yet. And then the third problem we face is the opioid epidemic, or the opioid crisis, or pick your descriptive term. And the United States is awash in opioids. The United States uses 80% of the world's opioids. And the problem with that is the potential for diversion, misuse, abuse, addiction, unintentional overdose. We've come to learn that heroin and since then fentanyl is substitution therapy for the inability of patients to get prescription opioids. They will get opioids. We know that prescription opioids and synthetic opioids caused nearly 50,000 deaths last year. The opioid epidemic in the United States is not related to surgery. It's related to the inappropriate prescribing of chronic oral opioids by primary care practitioners for indications for which these drugs are not indicated. But we're all suffering the consequences. Patients, practitioners, and governments have to react. They have to do something. So, for example, the Center for Disease Control in the United States came out with 10 guidelines for the use of opioids in chronic pain. And they emphasized that it was for chronic pain, but then if you look closely, recommendation number 6 was for acute pain. And they said you should prescribe the lowest effective dose and duration, but that nobody really needs more than 3 days of opioids, rarely 7 days. And what's happened is that almost every state in the Union in the United States has now written and passed legislation which restricts opioid prescribing. On average, it's a 5-day limit. And they're doing that in the best interest of public health, and they're very well-meaning. But we also know that 83% of patients are still using opioids 5 days post-operatively. If you only are allowed to have 5 days of opioids, what are these patients doing to take care of their post-op pain? Whose public health are we really serving? The same people who wrote those CDC guidelines came out with an editorial a couple of weeks ago, which basically said their guidelines have kind of been hijacked. They said that unfortunately some of the policies and practices which went into those guidelines have been inconsistently applied. The applications often go beyond the recommendations. And it's the potential misapplication of the recommendations to populations outside the scope of the guidelines that are problematic. And they called out surgical procedures as the implementation of their guidelines have been misapplied. We know that there's a 2% incidence of persistent opioid use after hospital discharge. A number of studies have shown consistently that 2% number. But the question is the opioid use a problem or is it a symptom of the chronic post-surgical pain? Keep in mind that 10 to 50% of surgical patients develop chronic post-surgical pain. So is it that surprising that just 2% are using opioids chronically? And are we really creating an environment in the operating room which causes addiction? So I don't think that the problem is the appropriate use of opioids for pain. I think the problem is the overprescribing of post-operative opioids, excess post-operative opioids, which creates this reservoir of unused opioids in the United States. The consequence is that those opioids can be diverted and misused. And there's now a fair amount of information which describes that. Looking at this, there's a systematic review published a couple of years ago, and they found that up to 90% of patients have unused opioids after surgery, whether they are inpatients or they're outpatients. They found that about half of all the take-home opioids go unused. Most patients stop taking opioids when they stop hurting or when their pain becomes a tolerable level. But the majority of opioids, once they go home with patients, are not stored in locked containers. And what happens is they're diverted. Anybody with a child over the age of about 8 knows what's in the medicine cabinet. When your kids visit their friend's parents' house, they know where to visit the medicine cabinet. People that come to your house for home repair or other things know to look in the medicine cabinet. Most people that I talk to, when I tell them to go home, and I ask them if they have opioids in their medicine cabinet, they say, of course, because I kept what was left over just in case I might need it. I said, go home and see if it's there. Almost everybody comes back with an amazing look on their face to say, they're gone. The bottle's there, but the pills are gone. So the message is they need to be locked up. But the other message is we need to prescribe less take-home opioids. So it's really unused opioids which creates this reservoir. It's the overprescription of post-discharge opioids which adds to the reservoir. But this shouldn't mean that we abolish the use of intra-op opioids for treating pain in appropriate settings. I think what it means is that we should use opioids smarter and better. So we said the unmet challenge was really to thoughtfully examine, not reactively approach the problem, develop rational opioid use, optimize the use of opioids, the selection of opioids, which, what, and when, and how much, and rationally address hospital-level policies to deal with the problem in thoughtful, rational ways. So that brings me to the clinical dilemma, and that is, how do we do this? How do we effectively provide analgesia throughout the intraoperative and post-op periods while we minimize the side effects? Ideally, we want drugs that have rapid onset, and we want drugs with a duration of action who matches the duration of pain. Over the course of the past 3.5 decades, as I've watched the practice of anesthesia, we've gone to shorter and shorter and shorter duration opioids. Fentanyl, sufentanil, alfentanil, remifentanil, and no fentanyl at all. But the 80% number hasn't changed. 80% of patients still report inadequate post-op pain relief. And then for really short duration opioids or no opioids at all, we just have to figure out what to do in the recovery room. So a couple of pharmacologic concepts. One is that teleologically, opioids which sustain a plasma concentration above a minimal effective concentration and maintain that above the minimal effective concentration are more effective than using short-duration opioids whose plasma concentration cycles above and below that effective concentration and causes patients to cycle from pain to analgesia and back and forth and back and forth. The other is with regard to respiratory depression, is that once you get a patient comfortable in the operating room in the PACU, if you don't give them more opioids, they can't suffer an opioid-related respiratory event. These respiratory events post-operatively happen when patients get more opioids. So if we compare opioids, we can look at their onset and duration. The quickest onset opioids are alfentanil and remifentanil. Sufentanil, fentanyl, and methadone have a relatively fast onset. Morphine has an incredibly slow onset. And if we look at elimination rates, remifentanil is eliminated most quickly and methadone is eliminated very slowly. It has a half-life of days. And so methadone is a mu receptor agonist. It's an NMDA receptor antagonist. It in and of itself is a multimodal drug. It's kind of like combining an opioid and ketamine or any other NMDA receptor antagonist. It's used throughout clinical medicine in acute and chronic pain. It can be used in adults and children, and it can be administered by a number of different routes. It has a very long half-life, which means the dosing is very infrequent. There are differences between the two enantiomers of methadone. Our methadone is the active enantiomer. The half-life is 1 to 2 days. It's extensively metabolized, and the metabolites are inactive. Now, applying the concepts to the use of methadone, the concept is that a single intraoperative dose of methadone, which sustains therapeutic plasma concentrations above the minimal effective concentration, provides much better analgesia than short-duration opioids where concentrations cycle above and above below that minimal effective concentration. And that a single dose of methadone given by a healthcare provider is safer than uncontrolled patient self-administration of opioids postoperatively, particularly during that 24-hour window of vulnerability. and to show you a cartoon of what this looks like. This is plasma concentration of methadone over the course of time. And what you'll notice is that after a very short redistribution phase, shown in the upper right-hand corner, we have a very prolonged rate of elimination, which gives you a very prolonged duration of effect. 20 milligrams of intraoperative methadone typically provides 1 to 2 days of postoperative analgesia. And it's the slow elimination which gives you the long duration of effect as long as your plasma concentrations are above that minimal effective threshold. So the first study which described this came out of Australia. It was published in the early 1980s, and they basically took a selection of patients, gave them all 20 milligrams of methadone at induction. A third of the patients went home needing no more opioid. A third went straight to orals, and only a third needed supplemental postoperative opioid. The patients that got methadone had less post-op opioid requirements. They had significantly less post-op pain, despite the fact that they all had unlimited access to PCA, and there were no differences in side effects. And this was a very cost-effective way of providing anesthesia. And every study that has been done since then has shown essentially the same thing. Another study in major back surgery compared methadone versus sufentanil in a total intravenous anesthetic with post-op PCA. And what they found was that the patients who got methadone had less pain despite PCA. They used significantly less postoperative opioid, and there was no difference in the incidence of side effects. And their conclusion was that a single intraoperative dose of methadone provided improved pain control for patients who were undergoing complex spine surgery. Another study which looked at this in complex spine surgery gave methadone at induction compared to hydromorphone. Anesthetic maintenance was sevoflurane and propofol, and patients had post-op PCA. They found that patients who got a single dose of methadone used much less post-operative hydromorphone. They also used less post-operative oral opioid. Despite using less opioid, they also had less post-op pain. They had less pain with at rest, less pain with coughing, and less pain with movement. And the patients who got a single dose of methadone had higher satisfaction scores than the patients who did not. The conclusion was that intraoperative methadone reduced post-op opioid requirements, decreased pain, and improved patient satisfaction. Same investigators looked at this in cardiac surgery. Cabbages or valves undergoing bypass. Patients were anesthetized with either methadone or fentanyl, and they were maintained with a volatile anesthetic. And postoperatively, they received morphine. The patients who got a single dose of methadone used less postoperative opioid. The number of patients who used more than 20 milligrams in the first 24 hours was substantially less than the patients who got an anesthetic with fentanyl. Pain scores at rest, pain scores with coughing, and pain scores with movement were all less in the patients who got methadone, and the patients who got methadone were more satisfied. So again, the same trend. Lower pain, less postoperative opioid use, enhanced pain management, and more satisfied patients. We asked a question in our institution: what about the potential for respiratory depression, sedation, or postoperative nausea and vomiting? So we looked at 3 years' worth of data, 150,000 cases, and we compared patients who got methadone for their surgical procedure or not. We used PACU discharge time as a metric. We used the administration of antiemetics as a surrogate for nausea and vomiting. And we used the administration of naloxone as a surrogate for respiratory depression. And what we found is that discharge times from the PACU were no different. The administration of antiemetics was no different. And the administration of naloxone was no different in the patients who got methadone. So our conclusion was that patients who got methadone weren't oversedated. They didn't have delayed discharge. They didn't have worse nausea and vomiting. And respiratory depression was not a problem. Another aspect of methadone is that it's very cost effective. We did a calculation and compared the cost of giving an anesthetic with remifentanil compared to the cost of an anesthetic with methadone. And I just picked a 4-hour anesthetic at random. In our institution, using retail prices, a 4-hour remifentanil anesthetic cost more than $300 for the opioid. The cost of methadone was $42, tenfold less. And lastly, we recently looked at this in outpatients. For a long time, I had been asked whether I used methadone in outpatients, and I said there was no data. And after several years of saying there's no data, I realized that the best thing to do was to get the data. So we've done a couple of studies. We did one in same-day discharge surgery patients. We did another one in 23-hour overnights. And we're now doing this in a large-scale study of 750 patients. But in this smaller-scale pilot study, we looked at patients who are undergoing elective same-day discharge surgery. We excluded patients with liver or kidney disease, patients who are opioid tolerant, and the collection of cases tend to be typical same-day surgery patients, lap choles, salpingo, oophorectomies, things like that. And we did a dose escalation. The first cohort was 0.1 milligrams per kilo of methadone. The second cohort was 0.15. It was double-blinded and randomized, and the control group was do whatever you normally do with short-duration opioids. And we looked at a number of metrics, including up to 30 days follow-up post-operatively. And what we found was that the intraoperative opioid use in the patients who got a single dose of methadone was much, much less than it was in the patients who got conventional opioids. And we stopped at 0.15 milligrams per kilo of methadone because this was a number which achieved the goals which we had. We also looked at PACU opioid requirements, and we found that the patients who got 0.15 milligram per kilo of methadone used much less opioid in the PACU. And if we looked at the number of patients who needed no opioid in the PACU, over half of the patients who got methadone at the 0.15 milligram per kilo dose needed no more opioid in the PACU. We looked at total use of opioids on the day of surgery, and it was much less in the patients who got methadone compared to conventional opioids, telling us that methadone did decrease overall opioid requirements. And we also looked at sedation. The patients who got methadone were not sedated, and we looked at PACU sedation using conventional scores, so that methadone was not causing post-op sedation. And then we looked at 30-day data. We looked at 30-day post-operative pain scores. We gave patients diaries to take home and said, rate your pain. And we were surprised by this because the patients who got a single intraoperative dose of methadone had substantially lower 30-day post-op pain scores. A single dose of an intraoperative drug having a sustained therapeutic benefit. This was a surprise. We looked at 30-day post-op opioid use, and we found that the patients who got 0.15 milligrams per kilo of methadone used significantly less opioid at home than the patients who got a conventional anesthetic. So what we were seeing was a sustained benefit of a single intraoperative dose of methadone with regard to 30-day pain as well as 30-day post-op opioid use. So the idea is that patients use less opioid, we can prescribe less opioid, and we'll have less leftover opioid in medicine cabinets. So the principles are basically the initial dose of methadone in the operating room has to be big enough so that you get your plasma concentrations above that minimal effective threshold. And the higher the concentration, without causing side effects, the longer the duration of analgesia. We do this for cases that are going to last for longer than 45 minutes because we need the drug to redistribute. In our institution, we don't prep and drape in less than 45 minutes, so that's not a concern. I caution people not to use regional anesthesia after they've given a dose of methadone because we use opioids to counteract pain and we use pain to counteract the side effects of opioids. If you've given somebody a large dose of opioid and then blocked them, they now have unopposed opioid effects. And now we get side effects. And lastly, avoid CNS depressants. Things like gabapentinoids, sedating antiemetics, dexmedetomidine, post-op benzodiazepines. And the reason is that we know from decades of experience that the combination of opioids, any opioid, and a sedative hypnotic potentiates the respiratory depressant effect of an opioid. And this is obviously true for longer duration opioids as well. So we avoid sedative hypnotics. Again, in practice, at induction, we give inpatients 20 milligrams of methadone at induction. We may cut the dose to 15 in those patients who are old or elderly or debilitated. The 23-hour outpatients, we give them 15 milligrams. In the same-day surgery patients, we give them 10. We don't weight adjust because these are conservative doses. Maintenance, it's what I call set it and forget it. We don't give patients any more intraoperative opioid. We give them a single methadone dose at induction, and we're done. It's important to remember that opioids decrease the need for hypnotic drugs, whether that's propofol or a potent volatile agent. They decrease the MAC by about half. So you need less of those drugs than you would if you are giving an anesthetic without an opioid. At the end of the case, patients have end-tidal CO2s in the high 40s to low 50s, just like most patients in a PACU have CO2s in high 40s to low 50s. So if a patient is breathing with an end-tidal CO2 of 35, let the CO2 climb. They'll breathe. And then lastly, in the PACU, we give additional methadone as needed, 1 to 2 milligrams every 5 to 10 minutes. And we stop at 6 milligrams because patients very rarely need more. And we want to go see them if they're still having pain after that. So in summary, methadone is a long duration, very effective, very cost-effective alternative to conventional short duration opioids. It fulfills the criteria of an ideal anesthetic. It's fast onset, long duration, and the duration of effect matches the duration of pain. The dosing is 20, 15, and 10 milligrams, relatively easy to remember. Patients get better analgesia, and they use less post-operative opioid, and they have higher satisfaction scores. In many ways, it is a one-drug multimodal anesthetic or analgesic. And I think it's probably underutilized. And lastly, we think of it as an opioid-sparing opioid. And hopefully I've convinced you of that. So as far as addressing the challenges that I set out, providing better analgesia, I think I've shown you that methadone does provide better analgesia than short-duration opioids. It's multimodal, and it's opioid-sparing. It addresses the issue of post-operative respiratory depression. If patients don't need additional post-operative opioids, they can't suffer a post-operative opioid-related respiratory event. And this may substantially reduce risk, although we don't know yet. And lastly, with regard to the issue of opioid diversion and misadventure, methadone decreases post-op pain, post-op opioid use. And if we can convince our surgical colleagues that they can send patients home with less or even no opioids, we reduce the chance for diversion and misadventure. So with that, I thank you for your attention, and I'm happy to take any questions.
Lee Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.